So welcome back to the final session in this AIDS 2022 pre-conference. My name is Solange Batiste, and I'm the Executive Director at ITPC, together with Jeff Garnett, the Deputy Director for Global Health on TB and HIV team at the Bill and Melinda Gates Foundation. We will be chairing this pre-conference session together. This session will focus on re-engagement, our favorite topic. With more people in high HIV-burdened countries in Eastern and Southern Africa now re-engaging than initiating treatment, it is time to reorient health systems to support successful re-engagement in HIV treatment services. There is also a role for differentiation at that point of re-engagement. A one-size-fits-all approach will not work for everyone. So we're going to have 4 presentations in this session, and then hopefully time for some discussion and Q&A. We both have no conflicts of interest. We are not standing at the podium to click the slides, so I'm just going to hand over to Jeff now.
Thank you, Solange, and welcome everybody to this exciting session on re-engagement. So I'm going to go through the order of speakers and their topics. Our first speaker will be Dr. Katie Godfrey, who's an infectious disease physician with an extensive experience in HIV, tuberculosis, and sexually transmitted infections, and the Senior Technical Advisor for Adult Care and Treatment at the Office of the Global HIV/AIDS Coordinator. Katie's presentation will be look at the changing epidemic from initiation to re-engagement. Next will be Kombi Zikombi, Research Manager at the Centre for Infectious Disease Research. Komba will summarise the evidence of why people disengage from HIV treatment programmes. Our third speaker is a medical doctor and a differentiated service delivery consultant for the International AIDS Society, and will be joining us virtually from the UK. Helen Brygrave has worked in HIV and TB programming across Africa and Asia for the last 10 years, and she will present on differentiation at re-engagement. Finally, Senior Head of Division for Programme Delivery and Deputy Chief of Party for Anova Health Institute, Ms. Diana Mokena, will provide an overview of the South African case for DSD at re-engagement, looking at the policy and implementation. These presentations will be followed by a moderated discussion to look at collectively engaging and contributing to shaping a collective way forward.
I don't know if we have another microphone, but we're happy to share mic. All right. Okay, so that was the run of the show, and we look forward to an exciting session. We want to also remind our lovely speakers to keep to time, or else we'll have to jump in. And we'll hopefully have some time for questions and answers at the end to keep the conversations going during coffee and continuing later on. Those who are online, please submit your questions via the online platform. And if you asked a question that was not answered as yet, please ask it again, because I don't think we're able to save the questions. So it's not that we were ignoring you. We want you to ask it again, and hopefully anyone from this panel can address those questions. Please engage the session via social media. And over to you now, Katie.
Thank you very much. Just the challenges. My name is Katie Godfrey, and thank you very much to Anna and others for inviting me. It's really a pleasure to address this particular topic. I have no disclosures. So we no longer think about engagement and re-engagement as a linear evolution from being not on treatment to engage. We understand now that it is actually an iterative process, and many people experience interruptions in treatment both early on and need to be re-engaged. PEPFAR does collect some data on this information. PEPFAR does collect some information on this topic. And so what I thought I'd do to set this topic up is really talk to you a little bit about the data that we do have, so that I can ask your advice and the people in this audience and on the panel's advice about how best to handle this. So here's a slide that shows the number, age, and sex of individuals with HIV supported by PEPFAR. You can see that the very largest number of individuals is in the older age group, as people age into that cohort, and there are many more women than men in treatment. This breaks it down by the treatment interruptions by age and sex. So you can see that that the absolute number of people who have interrupted treatment is greater among women than among men. But if you look at the total number of percentages, in other words, the percent of people in treatment who interrupted treatment, you can see that more men than women proportionally interrupt treatment than men. And I think that this is a really important point because it underscores the need for specific services that are sex differentiated. So looking towards, PEPFAR also tracks the when people interrupt treatment. Do they interrupt treatment early or do they interrupt treatment late? The pink, the numbers in pink show. And the bar graphs in pink show people who interrupt early in treatment, and those who in the dark blue show people who interrupt late. So you can see that although the numbers of people who interrupt late in treatment once they're well established on treatment are very high, the percentage, the proportion of people who interrupt early in treatment is actually very important. So in other words, what this is showing is that across most of the age bands, that about 10% of people who are newly on treatment interrupt treatment within the first three months of therapy. And this is a really important thing, I think, to get our heads around, because it really represents opportunities for intervention and opportunities for person-centered care. And maybe those opportunities have to do with specific challenges in that person's life. For example, are they working, as Lillian has eloquently mentioned? Can they actually get to their appointments? Can they manage all the complicated things that we ask people to do in the first couple of appointments? So this is an area that I think that we can all do better in, and I'm really looking forward to hearing some suggestions and solutions. So PEPFAR also tracks re-engagement. So we can look at the interrupters in terms of the age and sex information, but I think it's also important to look at who are people coming back, and what do we know about them. So PEPFAR defines returns as the number of individuals who are returning to care after having been out of care for a month. And really what that means since the last time that they had contact with the health system. I want to point out that this is aggregate data, so it doesn't follow a particular individual. So you can't say that we had this many people who interrupted care and this many people who returned care. But bottom line, from a statistical standpoint, I think we'd like returns to match the interruptions. So, as I've said, this is the returns, the individuals returning to care after having been out for 28 days. And we'd like that to happen. So here you can see that the returns do not match the interruptions, that many more people interrupted than returned. Here's the re-engagement by sex, showing that more women than men returned to care. And by age. And I want to point out that the largest number of people who do not return, the biggest discrepancy in the return to care is in the 25 to 29 age group. So we also look at the length of interruption, and you can see here that that there is the differences in 3 to 6 months and less than 3 months, and really the there's a large number of people who interrupt early in treatment and are successfully returned. So in terms of the re-engagers, the clinical questions that we want are really why do they come back, when do they come back, where do they come back, and how do they re-engage? But these are not questions that PEPFAR can really PEPFAR's data can really answer, and there are we are making some efforts using the electronic health record in places that have a good electronic health record to kind of get at that, but I'm not sure that those answers are going to be really quickly coming. So I want to kind of. So here are the interruptions in treatment disaggregated by sex and time on ART, and I just want to leave you with that because really thinking through that the number of that 8% or not, of people interrupt early. So I really do think it's the early interrupters that we really need to, and getting those people back into care, that it's actually really important that we can help. The important thing is though really the issue of the medical management for people who re-engage late is different than the management for of people who re-engage early. And if we have that opportunity, and I think it's really important, and it may involve specific tailored services for that person. So, as I said, the package of care on return is different. So they'll need, if they're interrupted for more than a year, they'll need an assessment for an advanced disease, including TB. And there's questions about when to assess the viral load. And really, the question about the timeline for resumption of less intensive DSD models is really important, I think, and particularly for children, the alignment with other family members. So that's all I have to say right now, but what I do want to do is acknowledge our interagency continuity community of practice. And in particular, I want to call out Michelle Williams-Sherlock, who is really, I won't say a wizard with the data, And I see Michelle here, so do you mind standing up? It's so often that the spokespeople present the data, the finished product, and it seems so polished, but it's really a whole lot of people who go into the work. So thank you very much, and thank you, Michelle and Lauren.
So our next speaker is Kombe.
Okay, thank you. So I'll talk about why people disengage from HIV treatment programs. My name is Kombatende Sikombe from the Center for Infectious Disease Research in Zambia. So we know that over the years, we've been dealing with engagement. We've been talking about this. Engagement in HIV care is really a challenge. And, we have about 15 to 20% of people who are living with HIV who actually reportedly are lost to follow-up. In some settings, in my region in Zambia, about 25 to 30% of these are actually reported lost to follow-up. It's sometimes even higher in some countries, up to 40%. And so even when people living with HIV, return to care after being lost, rates of repeat loss to follow-up in the future are actually very high. And so we do have some preliminary data from Zambia. And so this data really suggests that, about 30% become lost to follow-up again within 6 months of return. And so these interruptions, put people living with HIV at risk of poor health outcomes. And so unlike before, where the number of people not accessing treatment was the challenge, we're faced with a different challenge right now where, we need to try and re-engage people on treatment. So obviously understanding why disengaged people living with HIV, why this happens, is a key to care improvement. And so we know for the last 10 years we've been doing a lot of work around this, a lot of research that's focused on this key question. And so we know that they're key to understanding why different types of lapses in engagement occur. We also know that this can be an indication of the most at risk for poor outcomes. And so they can also help us really understand the success of our service delivery programs and accurately observe the effects of our interventions. So I'll just talk about this cascade. So from the time someone tests positive for HIV and gets initiated on treatment, we notice that a lot of people do drop out of care at every stage, various stages. And so, for those that have been disengaged from care, it's important to understand why this is happening because, there's a lot of things that lead to this. They have different experiences based on economic status, gender, but even across key populations. And so by explicitly capturing what's going on with people living with HIV, revolving in and out of each of these cascades, each of these steps on the cascade, rather, it becomes possible for us to ask important questions, novel questions, and really this updated cascade helps us reflect on the experiences of people living with HIV. So, to understand this health-seeking behavior, one may adopt this socio-ecological framework, that was developed by Maurice Mosheke from Zambia. And so this was to explore factors that influence decisions about engagement for people living with HIV. And so what's key in this holistic approach is that you have these individuals with, individual level factors, social factors, and health system factors, such as healthcare worker attitude, waiting times, treatment access, as well as the various factors, these various factors basically interact and influence patients' decisions. So I'll talk about this Venn diagram where we talk about reasons for silent transfer, disengagement, and changes required to return to clinic. And so these were cited in Zambia, a study that was carried out on a group of lost to follow-up patients. And so structural reasons here are represented in red, psychosocial in green, and the gold is the clinic-based factors. And so switching clinics was due primarily to structural reasons, disengagement largely due to psychosocial reasons, and then the changes required for a patient to return to care were largely clinic-based. And so structural reasons actually entail transportation being too difficult or expensive, and work requirements really interfering with access to care. So when we talk about disengaged patients, let's recognize that they're not all the same. And so this slide shows the 5 profiles of care disruptions. We have livelihood and mobility, mobility and family, for example, reported family work, school obligations, travel, as well as transport-related reasons. And this is work from Modi and the rest of the team in Zambia at CIDES. And so this slide also highlights clinic accessibility, such as reported challenges with attending clinic, doubting the need for HIV care, being uncertain around the HIV status or need, for clinical care. And so there's also a multidimensional, barriers to care, such as reporting numerous reasons across multiple domains. So in this slide, we have this interaction, this bar chart is basically saying that in the y-axis, it indicates silent transfers moving towards 100%, and then going towards 0 is our disengaged. And so what this graph is really telling us is that clinic-based barriers drive people living with HIV, with psychosocial problems out of care, and then clinic-based barriers drive people living with HIV without psychosocial problems out of your clinic to another clinic. So here, this is some data that's basically showing heterogeneity from 31 sites in Zambia, 31 facilities. And so each bar here represents one facility. Most of the reasons required here, you can see the green bar are really clinic-based factors. And then this is clinic-based factors, the stuff like spending too much time at the clinic, being afraid that you'd be scolded during your visit, and not being treated with respect when you went to the facility. And so because we can't, we can't allocate resources to all these facilities, or all these to address these barriers, this slide basically outlines how we might consider prioritizing specific areas, recognizing that heterogeneity does exist across facility. And so just to say that psychosocial and structural reasons were also prevalent, and so but perhaps people living with HIV actually see clinic-based factors as the rate-limiting factor for return. So there was some work done by Gossett in South Africa, and they reported that patients that exited care and then returned were more likely to be young, without a regular partner, and men receiving psychosocial support. And so those with a high CD4 count tend to exit care and then return after 4 months, probably because they felt unwell after some time. People living with HIV also are less likely to return if they had a previous gap in care, or originally sought care from an urban facility, or maybe they found that the ART clinic schedule was inflexible. There was work done by Chamberlain in Malawi, and so they revealed that the respondents reported a strong internal motivation as a reason for re-engagement. And so because they feared that they would, become ill or they would die if they did not take their ART. And so their work highlights that emotional and financial, support play a key role in really facilitating re-engagement. There was also a recent publication by Bisnoth, and they reported that 47% of patients, returned to care because they were worried about being off ART. And then a further 21% reported that access to services had become much easier. And so in terms of mechanisms of re-engagement, our team, led by Laura Barris, reported that patients want to feel valued. They want to have better relations with healthcare workers and improved access to treatment. So I'll be ending shortly, but most systematic reviews have focused on tracing related studies, and these looked at interventions really to encourage return to care, and not interventions to help you remain in care once you've re-engaged, once you've made the decision to re-enter. And so this recent review from Ali showed that re-engagement activities led to an average of 58% of people living with HIV re-engaging, 20% more than the standard of care. And so in our setting, we're talking about 7% in low middle income countries. And so re-engagement is even better if efforts to trace disengaged people living with HIV occur as soon as a visit is missed. Unfortunately, there isn't sufficient data where we can generate estimates of retention after they returned. So this is a slide on preferences on re-engagement. And so our team, led by Ingrid Wilson here and Ariana here, this slide basically highlights some of the preferences, according to disengaged patients. Staff being nice is really important to them. It determines the quality that they're receiving at the facility. Patients prefer longer refills. We've heard about the 5 months, 6 months MMD. And so in this study, we gave them the option of 5 months versus 3 months. And then there was a qualitative study that was done by Steph Top. And respondents often described inflexibility with visit schedules, as a barrier to re-engagement. So what does this tell us about, service re-engagement? There's a few things that we can do to meet the needs of disengaged patients. Healthcare workers ought to be really nice, welcoming, non-judgmental, accepting of patients. Patients who transfer when they want to. Re-engagement encounters, we need to encourage a better re-engagement encounter between the healthcare worker and the patient. And this really points to the interpersonal relationship. And so we can tailor our resources based on these multiple dimensional, sort of preferences or profiles, shall I say, to better provide services such as social support, as well as services for men in particular. I'm moving to the last slide, and if you allow me, just to talk about what we've done in Zambia. Disengaged people living with HIV cite healthcare worker attitude as being a reason for dropping out of care or even transferring clinics. And so in Zambia, we basically trained healthcare workers to be more patient-centered. We provided data on patient experience, feedback cycles to the facilities, and then the facilities responded to this data and set their own priorities to address the interpersonal barriers at these facilities. And so this is basically a cycle that keeps going on, and then we monitored this change over time and continued to, it's sort of like a QI approach, and so changed things at the facility. Thank you.
Thank you, Kambe. I'm excited in seeing the results of that continuous quality improvement. Good. Okay, thank you. So our next speaker is Helen Bygrave, sorry, who's going to be on a video, I think. Good. Thank you. Welcome.
Great. Thanks. Really nice to be with you. Good morning, good afternoon, everybody. I hope after the previous two speakers, we can all agree it is time for differentiation at re-engagement. And what I want to do in the next few minutes is really put forward to us all some concepts and ideas of how we might structure that differentiation and our services at re-engagement. And just say I have no disclosures to make. So I just want to start off by just flagging where re-engagement is already mentioned in the WHO 2021 treatment guidelines. Firstly, it's in the section on advanced HIV disease, where it mentions that clients re-engaging in care should be assessed for advanced HIV disease and offered that package of care. Secondly, re-engagement is mentioned in this new recommendation, which is a strong recommendation for HIV programs to implement interventions to trace people who have been disengaged from care and provide support for re-engagement. So what we've already seen over the last few years is a number of countries include in their operational guidance very clear standard operating procedures and guidance for this tracing. So these are some examples from Zimbabwe, Ghana, and South Africa, and there are a number of others we could have shown here. But I think our real question for today is, once we've traced that patient, what do we do when they actually come back and want to re-engage at our clinics? Do we treat all re-engagers the same, or is this differentiation needed? And currently, despite those two examples from the WHO guidelines, we don't really see any clear, specific guidance on the how to do this in terms of differentiating our services at re-engagement. We start to see a few countries, and South Africa and Zimbabwe being two, developing algorithms to try and address this differentiation at re-engagement. And as the previous speaker very rightly said, how do we need to adapt our services for clients who've previously been on ART and make sure that we really do address those health systems barriers that contributed to them disengaging from care? And importantly, that we support ongoing retention and sustained retention for these clients who have decided to come back to our services. So we want to propose, when we're thinking about how we differentiate our services at re-engagement, we think about these two buckets of ideas. So how long has the client been out of care, so the duration not on ART, and also some important clinical factors. So if we think about the length of time the client has been out of care, who are we going to say can go straight back into their DSD model for clients established on ART? What is the time period where we're going to say, it's okay, you can go straight back into that less intensive model? And what's the time period in our algorithm or in our approach where we are going to say, this client needs to have facility-based follow-up in those first few months on ART again, with the appropriate refill length of maybe 1 to 3 months after restarting care, very much as you would do with a naive client starting ART. The clinical considerations, so a basic clinical assessment. Is the client coming back clinically well or unwell? Are there stage 3 or 4 conditions? Are there psychosocial challenges that we've identified, or maybe uncontrolled or unmet mental health needs? Secondly, really importantly for people re-engaging, when do we perform a CD4? Again, someone who's clinically unwell, maybe when there's a previously documented or the last viral load was not suppressed, but also thinking about the time out of care. And maybe a suggestion, which we'll show in an algorithm later, is that maybe after 3 months or more, maybe we should be thinking about a CD4. Viral load, what do we need to look in terms of viral load when we're thinking about re-engagement? Did the client have a previous viral load in the last 6 or 12 months? And was that viral load suppressed? Do we have evidence that this client at some point in their journey has managed to take ART well and achieve virological suppression? And then importantly, when are we going to perform their first viral load after reinitiation so that we can enable them into less intensive models? And fourthly, to see this as an opportunity to make sure the client is started on the WHO preferred first or second line regimens, obviously ideally with a dolutegravir-based regimen. So 2 countries have used these considerations to develop a suggested algorithm for how we're going to differentiate our services for clients re-engaging in care. And what I'm just going to do now is just talk through the Zimbabwe algorithm as an example, just to flag where those considerations have been integrated into that algorithm. So firstly, at the top, looking at doing that clinical and psychosocial assessment to identify immediate clinical needs and mental health needs. Secondly, the algorithm addresses in 2 places when to perform the CD4, highlighting those with clinical presentations, clinically unwell, or had a previous unsuppressed viral load, and also in this algorithm for clients who've been out of care or not taken ART for more than 3 months. There is an indication to take a CD4 to assess for advanced HIV disease. Viral load. So in this algorithm, the previous viral load the client had is taken into consideration, and whether that viral load was suppressed in terms of how the re-engagement services are designed. And then guidance given on the timing of viral load after reinitiation. For those clients deemed stable and able to go directly back into their DSD model for clients established on ART, they will have their annual viral load according to the normal schedule. For those clients who were unwell or out of care for a longer period of time, the viral load in this algorithm is suggested to be taken after 6 months. And I just want to flag how that ties with the WHO viral load algorithm guidance, to flag that actually it does say obtain and review the result by 6 months. Often we see viral load being only taken at 6 months, and hence the results not being reviewed for some time after that. But to consider, particularly in this situation of clients re-engaging in care, that we see high suppression rates with dolutegravir-based regimens at 12 weeks, and suggest potentially that this viral load could be taken earlier, potentially at 3 months. Therefore, if suppressed, enabling that client to enter into our less intensive models and potentially remove these barriers for clients who may have to, being asked to attend clinics more frequently. Then thinking about the duration of time the client has disengaged, here in this algorithm stating that if the client has been out of care for less than 3 months, they can return directly to their DSD model, versus those who have been out of care for more than 3 months, who have a clinical assessment, a CD4 performed, and follow the standard follow-up schedule that a naive patient would follow. So my key messages are, as Katie has highlighted, that more and more people are we are initiating on ART, have already been on ART. And that at the moment, we don't have clear WHO guidance on the how to sustain re-engagement, including that important point of the timing of viral load after reinitiation. Clearly, we feel re-engagement pathways should not be a one-size-fits-all, and that these pathways should not become a barrier to retention, and we should adapt our approaches to address the client's individual access challenges. And we want to propose that when we're thinking about designing a re-engagement pathway, that these 2 considerations are put forward, considering the duration the client has been off ART, and also those important clinical considerations. Thank you very much.
Thank you, Helen. And could I remind people online to submit their questions if they have any for the end of the talks, and those in the audience to think of their questions. So our last speaker is Miss Diana Mokoena. Welcome.
Afternoon, everyone. I'm Diana Mokoena from ANOVA Health Institute, a PEPFAR-funded implementing partner working in South Africa. And I'm excited to be talking to you today about an area that I feel ANOVA really excels in, and that's translating policy into implementation and contextualizing it for the implementation space. Firstly, I've got no conflicts of interest to disclose. I think before we start talking about how we can differentiate at the point of re-engagement, I thought it was important to first look a bit at the South African care and treatment program and the landscape and how the landscape has changed over time. If you look at the graph on your left, it's showing the HIV care program in South Africa over the last 20 years. Just to orientate you on the colors, the green is the proportion of people that are not yet diagnosed. The yellow are those that are diagnosed but never been on treatment. The peach are those that were previously on treatment but aren't there any longer. And I think the one thing that really stands out is that there's an increasing proportion of people who know their status but are not yet on ART. The graph on the right is specific to Joburg, which is one of the biggest cities in South Africa and a district that ANOVA has been supporting for the last 13 years or so. Again, reiterating, when you look at the cascade, that 92% of the people know their status, but only 70% of those are on ART. This also just shows you the Joburg context, and it's in line with what Katie was saying earlier. If you look at the green bars, they're showing you the number of people returning to care quarter on quarter for Joburg, and the orange are those that are newly initiated. And what you see there is there's definitely more people returning to care, even in the Joburg context, that are newly initiated. This is a summary of the previous graph, but I think the point that I really wanted to emphasize here, we've combined the data for the year 2020 and year 2022 in those separate bar graphs. And when you look at 2021 alone, there's over 80,000 people just in the city of Joburg that reinitiated over a 12-month period. A lot of this was also driven by a Welcome Back campaign that we initiated earlier in that year. And this slide is just breaking down when you look at the group of people that are returning to care, the light blue bar is showing you those that are classified as restarts formally. And these are people that have missed their appointment by 90 days or more and assumed to have interrupted treatment during that time. But the darker blue is showing you those that have interrupted for less than 90 days. And a lot of them we understand are able to access treatment elsewhere during that period, so the duration of interruption is significantly shorter. I mentioned the Welcome Back campaign earlier. Part of that work was doing focus group discussions with patients, with clients that had interrupted treatment and returned, just to understand a bit more around the reasons behind interrupting and what they would need to stay in treatment. And I think it aligns with a lot of what Kombe was saying earlier about the Zambia experience. A lot of the main reasons for interruption have to do with life circumstances, mobility, being able to get time off work, distance from the clinics and such. And when you talk about the reasons for returning, a lot of it has to do with access being a bit easier relative to those life circumstances. What I wanted to highlight here is also just some lived experience comments from those clients that were in our focus group discussions that just highlights how patients that are people that are returning to care need to be differentiated or have different needs. The client in the blue bubble was a truck driver who obviously needed to access treatment while they were away, and they couldn't do that because they didn't have a transfer letter, which is one of the requirements in the clinics in South Africa. And in the orange, you've got another client coming from a neighboring country who was able to get refills and top-ups during COVID regulations up until the time that the regulations eased, and they were able to go back to their main treating clinic in South Africa. But if we don't differentiate at the point when these clients are returning to care, these clients would be treated the same. They would both be seen as having missed an appointment and managed in a standardized way. So my next couple of slides just focuses on how in South Africa the health system has tried to tailor towards the needs of their re-engaging clients. In terms of policy, I think we have quite an enabling environment. I think if you look at our adherence guidelines, as an example, they really facilitate linkage as well as retention in care for our clients and accommodate re-engagement should interruption happen. these guidelines are seen as an implementer's Bible, especially for primary healthcare level. They are quite comprehensive, service delivery orientated, and they come with SOPs that are really helpful on the ground. The part that I want to highlight on the right is what I took out of that is a summary of a minimum package that shows you available interventions from the point of diagnosis all the way to supporting a client on lifelong treatment. I want to highlight two things on that minimum package on the right. The one is once a client has been on treatment for 6 months or more, they are assessed and are classified as stable and as either stable and eligible for these repeat prescription collection modalities that we mentioned earlier, or they're classified as not being stable and needing additional support, which is often in the form of psychosocial support and counseling. The other part I want to highlight is really around this SOP 9, which specifically talks to the re-engagement process. So this is part of the 2020 updates that were made to the adherence guidelines in South Africa, and includes an algorithm that focuses on differentiating between two groups of clients, if you like, at re-engagement. So on the left is the green, who are clients who did not interrupt treatment and most likely stable. And on the right are those who are unwell and who did interrupt. And two things really stand out from this algorithm. The one is trying to fast track access to these repeat collection modalities for clients that we know and have established haven't interrupted treatment while they may have missed an appointment. And the second part I want to emphasize about the algorithm is the emphasis on the early viral load assessment. So for both groups of clients, the algorithm talks about assessing whether you've got a recent viral load results and whether that result is suppressed or not. So because this SOP was released in 2020, multiple priorities, the implementation has been quite limited. In collaboration with the DSD team from IAS, ANOVA has been implementing a toolbox of job aids to support the implementation of this SOP in the city of Joburg. We are looking at two main objectives. The first is to really assess the feasibility and the acceptability of the SOP itself in Joburg and similar settings. And then we've got a number of sub-objectives that we classified as secondary. We want to look at fidelity of implementation, especially as outlined in the algorithm and the job aids that we've developed. We also want to be able to quantify patients that are true re-engaging patients as opposed to just having missed appointment. We want to be able to describe the clinical picture of those re-engaging clients, measure indicators such as retention, viral load suppression for those that are returning, etc. So understanding that there's various role players at facility level that are involved in the process of a re-engaging client, we developed and tailor-made these job aids for specific groups of staff. The pinkish on the left is specific to reception staff, so your admin clerks. The middle one is for clinicians. And the blue one is more for our lay counselors, retention counselors, and the psychosocial staff that are involved in the psychosocial package of services. The key really principles around the SOPs and the job aids are three main ones. The one is that the first visit is critical. That experience at that first visit, I think Kombe also spoke a lot about how patients who disengage are prone to re-engagement and how attitudes and the experience at clinic level are really critical. So you will see in the job aids themselves and the tool, there's a number of these kind of reminders that are targeted at healthcare workers about being kind, about not being judgmental, and remembering that at the end of the day, it must be a positive experience for the clients. The second principle is around understanding that not everybody who misses or is late for an appointment is necessarily re-engaging or has interrupted treatment. We are using 14 days as a cutoff because in South Africa, you have got that 14-day grace period after your appointment. And also acknowledging that there are silent transfers, which is clients that are transferring between facilities without documentation. And then lastly, Also understanding, as has been stated earlier, that not all re-engaging clients have the same service delivery needs. I think because I'm out of time, most of my other slides was just showing you screenshots of what the job aids themselves look like, but you can go through that when you get the deck. I just want to go to, the last slide. So it's a 7th-month project that we are implementing at the moment, and we're really hoping to share some lessons learned from the experience that can inform how differentiation can work going forward. And then lastly, just my acknowledgements. Thank you.
Thank you very much to all of our speakers. And I just want to encourage you, if you have any questions, please sort of get yourselves organized. And if you're online, you can please type in your questions. So thankfully, everyone did stick to time. So we do have enough time for about a few rounds of questions. Perhaps I will start off. There are some questions online that I'll try to combine with some other things that Jeff and I are curious about as well. So maybe I'll ask 3 questions, and to an extent, everybody on this panel, including Helen, is still online, I suspect. Right, there you are, would be able to answer these questions. So first off, what guidance from WHO do you think would be helpful to countries to better support people once they are re-engaged in care? So a little bit on Helen's slides as well about the how-to to sustain re-engagement, including the timing of viral load. But is there anything else, and how can we use this session to kind of advocate for what we need to hear, the WHO needs to hear, sorry. Another question is around, very curious, around the re-engagement and the extent to which treatment literacy or health education plays into these factors. So often the problems we see in the health sector are the solutions are outside of the health sector, because many of them are structural and you can't address everything through the health lens. But I had not seen in this round, even though the previous sessions did, touching on treatment education and treatment literacy. So to what extent do you think that is relevant, and how does it play in here? And that also links to a question online, which is around the reasons for disengagement, considering other personal factors outside of clinical factors. And then one last question is around NICE providers. So we all know NICE providers. The issue of NICE providers who provide respectful care come through, study after study. But can you discuss findings on why healthcare workers might not be nice, quote unquote, to recipients of care? So what aspects of the healthcare system put pressure or reinforce this behavior, and what solutions do you think come to bear? So any and everybody can start. Okay, not everybody, one at a time. Who'd like to start? Komba.
Thank you. I'll take the last one. It's the one I remember. I think certainly, our team, Dr. Skazwa and the rest of the team, nice paper on re-engagement in CID, disengagement, reasons for disengaging. But I think what we showed is that, yes, across facilities, there's challenges across healthcare workers. Obviously, we know in our setting, there's economical factors, how much do they get paid, the quality of the facilities. When we spoke to healthcare workers, we actually did a healthcare worker survey. I wasn't able to show that today, really trying to find out what motivates healthcare workers. And so with what we've done in the PCC study, in terms of addressing NICE providers, something that came out of the discrete choice experiment work previously in 2018, as well as some of the DCs from Kenya on DSDs. The providers actually basically need to be reminded about why they got into care, into healthcare. And I think sometimes starting with them and listening to their challenges. So for PCC, I didn't go into the models. We started with the healthcare workers addressing the stress management, going into communication issues. So I think we do need to start with healthcare workers as well. But I think to touch on your point about treatment literacy in terms of clients, there is something that we did again on trained exit clients, where we notice that when you train patients, you sort of empower them, right? You train them to assess the quality of care they're receiving at the facility. And what we've seen is we've been doing all these exit surveys, and it's business as usual, satisfaction is high. But actually, when we did the trained exit client survey, it's not business as usual. They're not happy. There is a problem. And so I think approaches like the trained exit client survey could address sort of the treatment literacy and maybe educating patients on what they better demand for. Thanks.
Thank you. Anybody else wants to jump in? If you need me to remind you, it's about the WHO, it's about nice people, all right, nice providers, and treatment literacy. Helen?
Hi, Solange. If I maybe jump in on the WHO question, I think we want to acknowledge the algorithms that we've shown as examples. Have been pulled together by a fantastic group of experts from Zimbabwe and South Africa sitting around the table, really kind of putting our heads together in terms of how can we do this and how can we take away those potential barriers to future retention for clients who want to get back into services and want to restart art. But and as our South African colleague said, those algorithms really have not been kind of put into practice, and I think we need to do that. We need to document, and we need to kind of really be clear, how they work, and are we achieving that improved retention by differentiating our services in these suggested ways. And I think we need to work with WHO on really those two key points around when, for a client, how long do they need to be out of care before we say it's fine, you can go straight back into your DSD model, straight back into your community art group, straight back into your club, or not. And then I think, again, that timing of viral load in terms of, can we do it at 3 months, and then therefore, if suppressed, can we again get that client into a less intensive model and make it easier for them to get their care as they choose. All DSD models are by choice, of course. So I think those two key points, and I think we need to work as a community with WHO in terms of generating that evidence so that there can be clearer guidance, as I think a number of countries at the minute are grappling with this as we go forward. But I think it's important that WHO does try and give that guidance ultimately.
Thanks, Helen. Diana?
Thanks. Yeah, I just wanted to add, is this on? I wanted to add on the NICE provider responses. I think in addition to what Kombe's already said, what we've also found is having more streamlining the process and the system issues at facility level that really takes some of that unnecessary workload off the healthcare workers. I think sometimes the overwhelmness that people experience at a clinic is of our own doing, if I can say. For an example, in South Africa, there was a practice that if a client has missed an appointment, they labeled as a defaulter, they put at the back of the queue, they have to go past a counselor for enhanced adherence counseling first before they see a clinician. Those are all sort of unnecessary steps. If you look at the reasons why people disengage and the reasons why, and what they need coming back. So if you eliminate some of those, so that's what the SOP 9 algorithm is really attempting to do, help healthcare workers, both clinicians and non-clinicians, identify who really is a re-engaging client and needs more intensive services, and who can be slotted back into their routine care or their RPC. So I think things like that. And then what I also wanted to comment on is the second question around treatment literacy. That is absolutely critical. It's unfortunate that it didn't come out strongly in our presentations, but we've seen it with viral load suppression and the U = U messaging. It's really critical. We're not going to get there if we don't bring the client on board, if they don't understand what our services are trying to assist them with, and if we don't involve them in the solution. So it's absolutely critical. Thanks.
Yeah, I would actually totally agree with you on that. One of the things that I've thought about for many years is actually that that a huge resource that we're not utilizing utilizing well is the patient population. And really, professional patients can really model behavior for other patients. And it's really, I think that's so important. Just as, the nice provider question, just coming at it from the provider point of view, if you have 2 minutes per patient and they have 25 problems that need to be addressed at that particular time, it's overwhelming. And there's a little bit of, I'm not even going to say post-traumatic stress disorder, but certainly stress of like just the barrage of honestly, of human misery that kind of comes at you at a clinic sometimes, and it's really hard to take. So I think that decompressing the clinics so you can actually spend some time with each patient is really it's been huge in my experience, and I can't emphasize that enough. It's really slow it down. Take away the stupid admin tasks. In the United States, it's all about the electronic medical record. So you spend, 2 seconds with the patient, and you're doing all these like notes on the computer. So really slow it down. Make the emphasis on the interaction rather than on the paperwork and the data collection and all the rest of that. And I know that that's heresy coming from PEPFAR, but I'm also a clinician, so.
We won't quote you on that. Just wanted to say, and I think these are really very critical points. Just thinking about DSD putting a lens on sometimes the management issues that happen at the clinic, which is almost what Katie's also pointing to. I'll hand over to you now, Jeff.
Thanks. So we have a question in the room.
I'll just speak.
Yeah.
Hi, I'm Ingrid Eschen-Wilson from Washington University in St. Louis, and worked with Comba and the CIDRS team on a number of the projects that were presented. And I just wanted to highlight that one thing that we noted was the issue with people who silently transfer to new clinics. And in some of, we sampled them and we got viral loads on some of them, and we found that among the patients who had silently transferred, they had higher viremia than those who had remained in care. And I just wanted to flag the point that was made about silent transfers and the difficulties that they face when they get to a new clinic. And I wanted to ask the panelists if they have any of the algorithms that have been developed have considered how to facilitate silent transfers so that this barrier that occurs when they attend a new site is a problem when they don't have an official transfer letter. And I have another question. Earlier on, some data was presented from Mozambique, which suggested that patients who returned to care would be removed from their DSD model and would have increased frequency visits and more adherence monitoring. And I just wondered a little bit about what the panelists thought about increasing visit frequency when people return and the issue of punishment visits.
Thank you. So we'll take another question from the room before we...
Thank you all. Really some insightful points. My name is Charlene Donald. I work on a project called We Lead, where we focus on young women who are affected by displacement, refugees, and sometimes asylum seekers living with disabilities and LGBTI. Some of the countries that they are in, obviously, the issues are structural, but also at a clinical level, you see issues where people simply can't get treatment. Do you have any experience working with these marginalized groups where fear of returning because of their status has been an issue, and can you give some solutions for that?
Thanks. And then can you add your question quickly? Because we haven't got much time.
I am Haneen Abu Murra from Jordan, Middle East country. I would like to ask if we have a country doesn't have SOPs and policies for re-engagement. What is the role of CSOs and how the CSOs can have effective role in do re-engagement for people living with HIV who are interrupting from using the treatment?
Thank you. So 4 questions. Any of our panelists want to take on those questions? I agree entirely about the punishment visits and making things onerous when people come back. It's it seems.
I will just say patient-held medical record. No.
Yeah. Well,
I think that that's an answer to many of those things. I don't know how to implement it, but I do think that the recipient of care taking ownership of their medical care is critical, and how we do that and how we transfer that back is very uncomfortable, I think, for clinicians, but I think it's actually critical. It gets to something that Dr. Cordelia was saying in the last session about somehow there's this belief that the best medical care is provided in a hospital, whether that's from that's on the doctor's side or the clinician or the recipient of care side. And we know from lots of experience that's probably not. I know it's not true all the time. It's better for certain kinds of things, but not for other kinds of things. So I do think that it's sort of reimagining that whole the healthcare system so that it includes people who are generally well and people who and people who are not and need different kinds of care. So I don't know if that helps, but these are things that I've been thinking about a lot. Over.
Thanks. I'll just add to Ingrid's on the silent transfer. I think better facilitation of silent transfer. I think we did do something where we looked at the characteristics when someone goes to a new facility, what happens, and we sort of had a tool where we asked all these questions. And actually, there's a wastage of resources. It's repeat CD4 counts, it's repeat testing, and so something that we really need to look at. If we're talking about 40% of patients actually re-engaging after transferring. So I think something critical that I think PEPFAR and others are driving, and I've seen from Botswana, the OMANG number, unique patient identifier from the beginning, and I think that's something that might help a better facilitation of transfers.
Thank you. So we're running out of time. I want to thank everybody for their questions and the comments, and apologies if we didn't get to your questions. But it's been great to hear how DSD's been developing, and sort of to me, the reminder is that this is about making things easier for patients and providers is the central thing. Solange.
Great. Thank you, everyone, for a great session. I know there are still other questions, but we are around, so hopefully you can chat over the coffee and in the halls together. It's the benefit of being in person and not having to come off mute and try to wait your turn. Okay, so if you recall, am I on slide? Yes. If you recall the first session this morning, we heard how scaled DSD has enabled HIV treatment program resilience, right? So looking ahead, now we need to build and defend our resilient HIV programs. This means building back group models that were interrupted during COVID-19 and ensuring that 6-month ART dispensing is not the new one-size-fits-all. And also we need to support community-led and community-based models. It also means ensuring we integrate our HIV services to meet the needs of people, including around TB, sexual and reproductive health, and NCDs, as we heard earlier in the earlier sessions. In the last 2 sessions, we talked about new areas in DSD, transitions and re-engagement. So going forward, it will be important to identify solutions and to support transitions and enable re-engagement. Guidance is needed from WHO and policies from ministries, as well as support for implementation. Supporting times of transition and people who are re-engaging in care will be critical in the coming years as we work collectively towards the global 2025 and 2030 AIDS targets. For those interested, we also have a DSD content at AIDS 2022. We would like to invite you to join this satellite co-sponsored by IAS and WHO on expanding access to PrEP through differentiated service delivery. You see that Anna has me reading all her slides about all the sessions that you should go to. So these are important. Please mark them. The session will be held on Saturday, the 30th of July from 8 to 9 a.m. local time in room 517C and channel 5 for those who are joining virtually. And then we have one more of these lovely announcements around DSD Science Satellite. We also invite you to join us on Monday, 1st of August from 8 to 9 a.m. For this satellite on the science of differentiated service delivery. This session will be held in room 516, and all the details are there, so you can take a nice quick photo. Thank you very much.
So I have a few more adverts just in the last few seconds. There is a DSD course that you can register for and do online. There's a DSD website to visit with tools and evidence. And then AIDS 22 has a DSD roadmap for tracking where you can go to learn more at the conference. With that, thank you very much, everybody, for your presentations, your comments, and for your attendance. Thank you.